And what we're going to do is we're going to start back with technical stuff first. So
everyone, introduce Dr.
I'm Neal Shonnard. I'm an orthopedic spine surgeon practicing about 30 miles south of here. I am a community physician, like many of you will become. I'm in private practice like most of us up here at the podium. I've been involved with the development of registries, one of which we're going to talk about. Another one is a statewide registry in the state of Washington on spine fusion that has followed the outcome of 80,000 patients over a 2-year period of time. So it's a pretty big database. And one of the talks I'll be giving you, the second talk, is on the merits of registry and how they'll be impactful for your lives. And I'll advocate that you all enroll your patients in registries.
I think Dr. Shonnard is kind of undermining how big the contribution he has to the registry and assessment, outcomes assessment scenario here. Pivotal player in getting registries started in lumbar fusions, and associate director of the Spine Scope Registry. He works with interested doctors who assess and improve spine care for all residents of Washington State and nationally. Please welcome Dr. Shonnard. Please.
So this is a slide that, here we go. This is a slide that you saw Doug in one of Doug's talks. And what Doug did was he just animated a guide wire coming into position. But what these colored dots show us, let's see if I can get that, there it is. What these colored dots show us is they're blue, orange, blue, orange, blue. And each of the blue, orange, blue, orange, blue represents the comparative dot in the 3 views of the trajectory of a guide wire going into the target. So as Doug was saying, it's a vertebral body width off to the side for most folks. And that's your start point. And you visualize the track, and at each of these colors, it represents where the guide wire is going as it heads for the center of the vertebral body at the anterior longitudinal ligament. That's your end point. And what you see with the wire is the X-ray representation of the pedicle that you see is where the wire is. It's the condensation of the cortical bone at the narrowest point of the pedicle. And the pedicle is wide at the top and the bottom, narrowest at the center, and that's what you see on the AP view. So the classic dictation for a transpedicular approach, to go down the bone tunnel, and the bone tunnel is what surgeons use as an access for instrumentation. Number 1, the instrumentation stays inside the bone. Number 2, it protects you from the neural elements. And number 3, it gives you purchase in the anterior body from a posterior approach position. And what you see with the AP, and the way the dictation commonly is dictated, is that the trocar coursed from the lateral border of the pedicle on the AP and reached the medial border of the pedicle simultaneous with reaching the posterior longitudinal ligament level on the lateral. So when you're doing kyphoplasty, you classically set up an AP and lateral C-arm, and you shoot. Now, once you get really good, you don't need the lateral, because the pedicle is almost always 18 to 22 millimeters. That's the thickness of your index finger. So when the guide wire is docked on the transverse process at the pedicle, where the pedicle and transverse process meet, you simply take a blue marking pen and you mark the guide wire 1 finger breadth above the skin, and you angle it in so that it reaches that, the blue mark reaches the level of the skin at the moment on the AP that the wire is at the narrow part. And what that means is the wire is not here. That's what you're seeing. The tip of the guide wire is actually here. And remember, it flares out. So you are safely within the bone the whole way. Initially, you'll start with AP lateral, AP lateral, AP. You'll irradiate yourself until you glow in the dark. But then you'll stop doing that.
Neal,
you'll get to pass the...
Neal, if I might add, the alternative approach in looking at it in the transpedicular approach is a lot of us here are interventional pain management trained and looking at things in a Scotty dog fashion for transfer animals, which we do all the time. And we're looking at a transpedicular approach. The alternative is also kind of looking at an oblique view and going down the pedicle in the oblique view and using the same rules here of not transgressing the medial line of that pedicle before you enter with the lateral, the vertebral body, and the lateral aspect. So the way I look at it is that getting that view and going right down the pedicle in that view as well.
Yes, and that's also one of the ways we're trained to place pedicle screws. It's called the axial, we call it the axial view. You're looking down the axis of the pedicle. When you integrate this into your mind, what you'll learn as your landmarks is your start point, your checkpoint that makes sure you never violate the medial cortex, and then both guide wires will end up on the lateral aspect of the spinous process. Lateral on the right, lateral on the left. In the center of the vertebral body on the lateral view. That's perfect trajectory. Now it's good to do this over and over and over and over again in the straight spine like you are seeing in the cadavers, because you're not going to be treating straight spines. You're going to be treating wicked scolioses with collapses and fractures, and getting facile with the normal anatomy will allow you to get the orthogonal view of whatever wicked scoliosis it is. And remember, always bring the patient to the x-ray. Don't bring the x-ray to the patient. Leave the fluoroscopy in orthogonal positions and bring the scoliosis into AP lateral orthogonal views so that your brain always references the vertical lines in the walls of the building and the tabletop, because your brain will be like an artificial horizon for a pilot. It'll tell you when you're off tilt, and that if you bring the patient into perfect orthogonal view, you can always use your x-ray references and be anatomically accurate. All right. So these are the different variations in start point that you will use in a transpedicular view. The transpedicular approach is the same in all of these, but where you start allows you to access the fracture differently. So if the superior end plate is fractured, you're gonna be aiming for the inferior end plate. You're gonna do a high to low approach. If it's the reverse, you'll do a low to high approach with your entry point on the pedicle. And it's just a joystick. So when you're setting up the lateral, the gun is here, image receiver is there, the arm is looped over the patient's head, the patient's face down. And the AP comes in, you want the gun very close to the body because you don't want it conflicting with your AP. And in big people, that gets to be a challenge. So that's your basic setup. Your start point depends upon so in the lower lumbar spine where the pedicle angle goes into the 35, 45 degree position versus the upper lumbar spine where the pedicles are almost straight up and down. So you're changing your start point based on the imaging axial view that tells you the angle of the pedicles. Straight up pedicles, you're gonna have a straight up start point. So this is a pretty vertical pedicle. So the start point is relatively close to the lateral border. If the person is bigger and it's in the lower lumbar spine, your start point just shifts out. And they're stab wounds, so if you're not in the right position, you're putting too much tension on the skin, quit. Start a new start point. Bipedicular. So in this case, you're getting the balloons, again, on the AP view, they're kissing each other at the level of spinous process. The balloon inflates in the anterior 2/3 of the vertebral body. Remember, that's where the greatest deformity is. And you can alter your balloon position to address the fracture. So you can shift it to whatever position best addresses the fracture. And when you inflate, you get the fill patterns that go from the medial border of the pedicle on one side to the medial border of the pedicle on the other side, because that's where your strength is. And troubleshooting. So in this circumstance, what you see on your lateral is you're in the middle of the pedicle, but you're already at the medial wall. So this is right where that wire was. So you know that you're about to violate the canal. So very simple to just redirect. And initially when you're starting to do this, walk your way down the pedicle so that you get this as muscle memory. And then when you start to lateral, you end up with, so you're not, remember, here's your, on your AP view, that is where you want your guide wires touching the lateral aspect of the spinous process, which is the spinous process is orthogonal, it's right in the middle. So you want your guide wires there because now your device is going to be out here to the outside and you won't get the proper lift or fill. Let's see. And this, referencing back to these points, when you learn them, you'll always safely place your... So now if you wanted to do a unipedicular approach, again, the principle is medial border of the pedicle on one side, medial border of the pedicle on the ipsilateral and contralateral side. So in this circumstance, your guide wire is going in on one side. And if you've got to reach the far side, then all you do is change the angle of approach. Back your device up to the base of the pedicle, lean laterally, go back across. And you were actually seeing Doug do that yesterday when he was modifying the position of his guide wires. And this will accomplish the same thing of getting cement all the way across. Uh-oh. I'm not getting advance. Nope, I'm not. And so I will, could you, yeah, it's not advancing for me. And then again, if you would. And now we'll start the other one. And let me just see if this, I hope this works. Otherwise, I'm going to have to do it differently.
Is that not working?
I'm going to try again. Nope.
I think it's just,
Yeah, it might just be a dead battery.
so I can try that one.
Yeah, thanks. All right, so data backbones. I'm going to reference a couple of registries that have been built recently and the effectiveness of it. We'll focus on one that's relevant to you all, and that's vertebral compression fracture. But the principles of registries are surveillance, meaning you track what you do. Because if you do good work, you want to show how long that good work lasts. And you want to link it to the cost that it took to get it done. Because that's the value equation. Is the cost and the duration of benefit are the value equation. And that's something that's missing, but we are building it. So you all have come to notice that you're getting measured in many ways. You're getting measured by health systems. You're getting measured by your outcomes. You're getting measured by consumerism. And the consumerism is the Press-Ganey scores. The rating for your facility might be based on how many parking spots you have and how quickly you saw the next, or if the person had a bad day that day and the dog died at the vet, your Press-Ganey score goes through the floor. So there are a lot of things that you get measured on. And some of them are your capabilities, some of them are not your capabilities, it's your sight. But the important thing to understand is that the things you're getting measured on, you want to be real world, and you want them to be real time. And Doug commented about this earlier. The difference between the randomized control trials that he spoke of is they are the Kodak Instamatic camera, and registries are GoPro. Registries show real time. They show what is in your immediate environment. They show what is above your immediate environment. They show the landscape. They show the time of day. They show so much more. They are what is happening all across the treatment field, whereas the randomized control trial is one specific photograph of data at one point in time. In registries, you tweak them. If you find that there's an error in the database, you change the metric. So you can't do that with randomized control trials. You change anything, trial's over. But with registries, you tweak them, you modify them, you perfect them, and they become more and more powerful. So it's a Polaroid Instamatic picture shot versus a GoPro. You got to know what you're doing when you get into registries, whether you're looking to do quality improvement, or you're looking to do research, or you're looking to do cost or regulatory. It always involves committed young minds because they're the drivers for all of this. And you all involve the 6 Ps: the patient, the physician, the payer, the purchaser. Payer and purchaser can be, so some purchasers are Amazon, Microsoft, Boeing, Weyerhaeuser. And the pharma and product and device manufacturers. The publications are for those who are academic and they want to work on publications. Registries are quality improvement initiatives. They measure what you already do, and they use the same ruler for measuring everybody. So they want heterogeneity. They want all of the different ways that you practice. They want all of the different ways the disease condition comes in. Randomized control trial wants it just at one site, just with a certain number of doctors, just for a specific treatment.
Sorry about that. I don't know why that's making all that noise.
Let me don't know either.
Let's use that one.
So the registry has the ability to really look at the real world because it's not a contrived circumstance from the beginning, which is what the randomized control trial is hugely improved if it's based on registry data. So you go through the registry data, you'll see sub-cohorts. You do the randomized control trial in the sub-cohort, you'll get fabulous results. But the first step is the broad population, and that's what the registry does. So when you look at heterogeneity, it's like a bicycle ride. So this is Steva. So the bicycle ride shows your path, but it also shows your terrain, your change in altitude. So it embraces all of the aspects of the bike ride, and the heterogeneity of registry looks at all the conditions, all the treatments, all the different ways you can do things, and what it asks is a ruler. Everybody gets measured by the same ruler. So for spine fusion, everybody had to have their diabetes recorded, tracked. The antibiotics had to be given on time. I hope I don't ignite. And for vertebral compression fractures, every single maker of product was recorded and tracked and measured using the same tool. And this is what the heterogeneity looks like for augmentation, percutaneous vertebral augmentation. You have the manufacturers You have the techniques, and if there's anything other, that gets recorded. So all of the ways of treating are embraced, and none of them are biased. However you want to record this, and in that way, with hundreds and thousands of patients, you can see what works and what doesn't work. That's a real blessing of it. You can see what works and what doesn't work. As physicians, you participate in setting up the metrics. What is it that you will measure? And you get to see that you can change behavior by doing what's called the Hawthorne effect. And the Hawthorne effect is, think of it as shining a light in a crack house. All the cockroaches run to the corners. So when you shine a light on medical treatment, all of the cowboys and cowgirls stop misbehaving. Just by shining a light, just by telling them, we're gonna do a registry. When you're enrolling patients in registry, it focuses you around what is it I'm doing, what is my intention, and what's my checklist, and how am I gonna get this done? So it automatically improves quality just by the Hawthorne effect. If it's done from a grassroots perspective, it has sustainability. If it's imposed, not so much. So this is examples of how you change physician behavior with the Hawthorne effect. So this is general surgery, this is colon resection. And a leak test is what you did as a kid with your bike tire. So the tire's leaking, you took the tube out, you patched it, blew it back up with air, stuck it in the sink. If there are bubbles, the patch isn't working. Do it again. If there are no bubbles, you put it back on your bike, put the tire back on, you're ready to go. In the colon, when you open the abdomen, you resect the colon, you want to stress test the anastomosis. So a rectal tube is placed, air is placed into the anastomosis region, and the belly is filled with water. If bubbles come up, your anastomosis leaks. So what we did in the state of Washington, we just put the metric on the registry. We didn't say anything to anybody. If you don't test your anastomosis, that's your business. So it's a yes-no. It's called a signal metric, yes-no. So when we started the registry, that's 2005, less than half of the surgeons tested their anastomosis. More than half of the surgeons reconnected the bowel, sent the patient to the recovery room. Each year, however, behavior changed. And the reason the behavior changed is the registry also tracked readmission, ICU stay, mortality, reoperation. And it happened to the surgeons who didn't test the anastomosis. So the Hawthorne effect changed physician behavior. Nobody got kicked off, nobody got sued, nobody lost privileges to their hospital. Their behavior changed by the Hawthorne effect. Non-coercive behavior change. This is behavior change in patients. So we just put in the registry, smoke, not smoke. And we tracked fusion failure, hardware failure, ICU stay, readmit for the 2-year duration. The physicians came to find out that, oh my God, my smoking patients are doing a heck of a lot worse than my non-smoking patients. And physicians and patients came to know this, and the behavior changed. And with registries, your numbers are so large, you can do what are called subcohort analyses. And from a statistical position, there's a lot of information in that slide. The great thing about registries is they lower costs. They get rid of the variations of treatment that all of us have. Some of us have eminence-based. Our eminent professor told us, Doug Beal told us, we're going to do it this way, that way, the other way. But when you get in a registry, you find the variations that are highly successful, and everyone migrates to the successful forms of treatment. Toxic variation is what makes medicine expensive, and this helps to improve it. And the costs to patients, the misery and suffering goes down. So this is the vertebral compression fracture registry that Doug was talking about earlier. And what you see here is this is community clinicians all over the place doing whatever technique they wish. And what you see is dramatic improvement in patient pain. So when you look at this pain scale, this is an absolutely miserable woman. Most of these are elderly women. And she's suffering from destitution. The fracture causes destitution, disability, and death. The 3 Ds of osteoporosis are destitution, debility, and death. And this function scale is someone who, 24 is bedridden, hospice. 21 is can't dress, can't clean house, can't walk, can't sleep, absolutely miserable. And this score is dancing on the table on New Year's night. You're happy as can be and life is good. So these are dramatic impacts that are immediate. The MSID I've embedded as the red zone, the minimally important clinical difference, and the MSID is crossed immediately at the time of treatment. And the improvements are threefold, MSID. Whether it's pain or function, it's threefold, the minimally important clinical difference. So this is some of the most dramatic impact you can have in the treatment of medicine. I am unaware, in orthopedics and in spine, there's nothing that matches this. And you should learn to do it, because as Doug mentioned, the population with this condition is going to double in your practice lifetime. And right now, 80%, 4 out of 5 women who have osteoporosis are not being properly treated. So the registry was done in this circumstance because one of the Medicare vendors wanted coverage with evidence development. They came to us and said, can you build us a registry that'll prove this kyphoplasty does or doesn't work? And we said, oh yeah, we can do that. And it, in fact, does work and does work beautifully. So this is the health utilization data, healthcare utilization data that Doug was referencing earlier from one of the hospitals participating in the registry that strongly argues you should immediately treat. And remember from your basic training and internship, there are no fractures in orthopedics that are neglected for 6 weeks. If you got a broken wrist, it gets treated. You got a broken ankle, it gets treated. You have a broken spine, the notion that you should wait is not only irrational, it violates your ethic, even though the regulators will say otherwise. And it triples the cost. Non-operative treatment triples the cost. This is Journal of the American Medical Association, March of last year. An original paper on the outcomes. We developed a predictive model that a patient can come into my office, I use this tool, and they plug in their name, I plug in their insurance and their diagnosis, but they put in whether they smoke, whether they're using narcotics, whether this is the first time they've ever had a spine operation or not. They put in their own pain, and the ODI score is not on the sheet, but they put in their function score. And then they hit a calculator button that says, predict my outcome. And you can see here that a 45-year-old female who is smoking, has L&I insurance, has failed to have a healing of a previous fusion surgery, and is using narcotics, with this pain score, has a 1 out of 10 chance of success. And so what I tell them is, well, you can't change your insurance. When you're in the L&I system, you're captured, you can't get out. So change the things you can change. And if you change the narcotics and you change the smoking, that score immediately pops up above 50%. And so you can use this tool, and this is what registries will give you in the dashboard that you have in your office for your data set and all of the data set, so you'll be able to compare yourself with it. And you can use these as decision-making tools, shared decision-making tools.
Is this free?
Nothing in life is free. So if you imagine, so this is for spine surgeons, but you can see the context of a predictive tool, that if a young person who's got no risk factors, has an established diagnosis for which surgery helps, has a severe problem with pain in the leg and dysfunction, that if you operate on that person who has private insurance, your success rate is, as you would anticipate, 9 out of 10. However, if you start eroding things, so same sex, different insurance and different opioids, same disability scores, whoop, there went 10%. It has nothing to do with your skill. But the registry gave you information around patient characteristics. It's got nothing to do with your skill. Same surgeon, same operation. The patient characteristics are different, and that's what eroded the score. Similarly, and we'll take it all the way to the end, and you just see it decline. So here's a 25-year-old with all the risk factors, has a surgical condition and exaggerated functional outcomes. So there's behavior, functional behavior, and there's a 1 out of 3 chance that that patient's going to get any better. And that's what predictive, this is the paper, an original investigation means it's something that's never been seen before. And that's what the registries will do for you. Number 1, it'll empower you. Number 2, it'll improve you. Number 3, it'll lower the cost, and it helps patients make decisions about what works and what doesn't work. And when you're done with it, and you make these improvements that you can, this is quality improvement. This isn't research. You're improving the quality of what you already do, so you don't need an IRB. You figure out the best way to do what you do. You can add some questions to, what's the next level? So you heard about antibiotic powder, and I mentioned to you that the data on it came from this data set, 80,000 people. And then you can put research projects. These are randomized controlled trials on the medical treatment instead of operative treatment of appendicitis or small bowel disease or obstruction. You can put research on top of it, and that research will be much more powerful. And I don't know whether you all noticed, but in the Wall Street Journal in January, Bezos, Buffett, and Morgan Chase Diamond made comments about bringing predictive capabilities to their employees because their business requires them to be able to predict their production. So if you're building aircraft, you have to know how long that patient is going to be out, because that's an important patient on the assembly line. And so this is, and the registries are going to empower all of this data. Lastly, each of the stakeholders has a self-interest motivation, and you must abide by that. Self-interest is a good thing if you harness it. And each of the self-interests are satisfied with this data because you become a trusted source for trusted data. And that is registries in a nutshell. Yes?
So are these state-run, or is it like...
Oh, no, so Spine Scope is a state-run, it's the only one in the union. It's the only state in the union that's doing it. So our experience out here with this is more than others because we have skin in the game and we're pursuing it. But the vertebral compression fracture registry that I was referencing, it's got patients from Doug's practice, from my practice, from California, so that registry and the registries that are going to be following that model are across the country.
Where do you find them?
Where do you find them?
Yeah, how do we access them?
Yeah, so first off, you're in a group here that participates in it. So Glenn does, Doug does, I do. And your societies, Society of Interventional Radiology endorsed. So how many of you are IR? There you go, so your societies. The national societies are trying to engage in them again. NAS tried about it 15 years ago, and it didn't quite get traction. But so you want to reach out to those folks who are doing it. And spinal cord stim needs to be in a registry. Remember heterogeneity. You can have this pulse pattern, you can have that pulse pattern, you can do it with a DRG and a BFD and an LMNOP and XYZ, and all of them get tracked. All of them get measured, and all of them you can look at with huge numbers, as you get the numbers for everybody. Any other questions? Good. We're done.